Now the topic is sexual activity and cardiac disease. See, the reason behind to keep this topic is most younger adults who experience an acute MI are sexually active before the acute MI episode, but little is known about sexual activity or sexual function after the event. And it is very much sure that it is neglected area from both sides, from the doctor side and from the patient side, due to the social stigma. And nowadays, heart diseases are common in the age group less than 40 years. So let me ask one question. How many of you are asking question about sex life post PTC or post MI patient or any patient with cardiac disease? And do you feel that this is really an important issue to address by treating doctor? I request all of you to message in the chat box. How many of you asked the question about sexual activity post MI or other cardiovascular diseases? So this is the case almost before 12-14 years that a male of 36 years of marriage life had a inferior MI and for that PTCA was done and his ejection fraction is 60%. TMT is almost 12 minutes without symptom post 2-month PTCA. But there is a myth that stent means no sex. So there were some personal issues and divorce 8 months post PTCA. And the reason behind is absence of sexual activity. The bad part is there is no counseling about sex life post PTCA done. Either the patient is asking the question or not by the medical service providers. So let's see what is the science is talking about sexual activity post cardiac events. So this is a very good article on the National Library of Medicine. It's telling that cardiovascular changes resulting from the sexual activity and sexual dysfunction after MI. So they concluded that because sexual dysfunction negatively affect the lives of people, providing guidance to individuals with cardiovascular disease, especially after acute MI, may be crucial factor in determining quality of life and should be incorporated in day-to-day clinical practice. This is a very good point discussed in the Medscape that we all have a mental setting in our mind that sexual dysfunction has traditionally been domain of the psychiatrists, urologists or gynecologists. But with the growing recognition of sexual dysfunction and cardiovascular disease, often the general practitioner and the cardiologists are now getting into the act to resolve this problem. In one article in 2015 of American College of Cardiology, they said that it may be safe to resume sexual activity following myocardial infarction, and MI is rarely caused by sexual activity, according to a research of this paper, which is published again in September 2021. Now, in the September 20, resuming sexual activity soon after heart attack linked with the improved survival, this paper is conclude with that returning to the usual level of sexual activity within a few months after a heart attack is positively associated with long-term survival. Sexuality and sexual activity are marker of the well-being. Resumption of the sexual activity soon after the heart attack may be a part of one of the self-perception as a healthy, functioning, young and energetic person. This may lead to a healthier lifestyle generally. Maintaining or increasing the frequency of sexual activity within the first 6 months after a heart attack was associated with 35% lower risk of death compared with the absent or reducing frequency of sexual activity. So these also we should keep in the mind. Now that European Association of Preventive Cardiology also concluded in January 2022 that resumption of the sexual activity frequency within the first month after MI was strongly associated with improved long-term survival, highlighting the need for the sexual counseling shortly after myocardial infarction. Now, Canadian Journal of Cardiology said in a very good article of what sex is safe for the heart patient, a new approach using ketomy model. This is a very good model. We will discuss in the next slide, but they said that kissing and touching is as good as slow walking, Then there are different kind of sexual activities, and they said that to reject the organism is a we will use the almost get a 3 to 5 minutes, and it is as good as we cross the street on the moving vehicle. It is the faster uh, activity. So they during this Canadian Journal of Cardiology, this article, sexual activity in heart patient, in this article they said that sexual activity, particularly coitus, may be major aspect of health related quality of life, and is often considered the most pleasant and rewarding exercise performing during the entire life. They also said that considering the rationale for the exercise prescription, sexual activity is typically well tolerated by the most clinically stable patient with the heart disease. And they advise to follow the ketone modules. Now let's discuss what is the ketone modules. Thus, they said that patient with the low risk, it means the stable angina, patient with controlled hypertension, they it means they are almost getting uh, 3 to 5 minutes on the treadmills. They should follow ketone models. It means ketone is the abbreviation of this. Ket means kissing and touching. Ketone means kissing, touching, and oral sex. And ketone means kissing, touching, and all. These are the different activity what the human being is performed during the sexual activity. So they said that low risk patient can participate in the ketone modules. Then intermediate risk, it means that patient is having a NYHA symptoms of class 2 or 3 or the moderate stable angina, and those who are performing 2 to 3 minutes in the TMT, they can have a ketone models, and patients are high risk. There are unstable angina. They are not able to NYHA class 3 or 4 group of patients. They can follow the KIT modules. It means also kissing and touching. The sexual activity and counseling in the first month after the acute MI among the younger adults in United States, studies was that they said that sexual activity may be resumed after 1 or more weeks by a patient with uncomplicated MI and without cardiac symptom during the mild to moderate physical activity. The European Society of Cardiology says that resumption of the sexual activity after AMI should not be needed if patient is able to tolerate the physical activity. About the sexual activity in angina, they said that coital angina, also known as angina of Daimler, that occurs during the minutes or hour after the sexual activity represent less than 5% of all angina attacks. It is rare in a patient who don't have angina during the strenuous physical exertion, and more prevalent in sedentary individuals with severe coronary artery disease who experience angina with minimal physical activity. So if a patient can achieve an energy expenditure of 3 to 5 minutes without demonstrating sign of ischemia during the exercise testing, then risk of ischemia during the sexual activity is very low. In the one article at circulation, they recommended for the sexual activity for the coronary artery disease that sexual activity is reasonably for the patients with no and mild angina. Sexual activity is reasonable 1 or more week after uncomplicated MI if patient is without cardiac symptoms. And also they said that sexual activity after CABG they can perform after the wound healing or 6 to 8 weeks after the CABG. Then other non-coronary open heart surgery same after the 8 weeks of the sternal wound healing. And then sexual activity should be deferred for the patient with unstable and refractory angina until their condition is stabilized or optimally managed. Now it is the same thing. The patient with stable IHD, previous MI, and post PTCA, if they are able to perform the moderate activity, exercise level or 3 to 5, or they are able to cross 3 to 5 minutes on the treadmill, they can actively participate in the sexual activity. The recommendation for the post-CBG and non-coronary open heart procedures, it is generally recommended that sexual activity be delayed for 6 to 8 weeks after CABG and non-coronary open heart procedure. After successful recovery after CABG, sexual activity is usually resumed and sexual satisfaction is usually maintained for many patients. Now, for the heart failure, they said that sexual activity is reasonable for the patient with compensated and mild heart failure. It means NYHA class 1 or class 2. But sexual activity is not advised for the patient with decompensated or advanced heart failure. It means patients falling in the group of the NYHA class 3 or class 4. They can resume the sexual activity once they have stabilized with the optimally managed pharmacological management. Now about sexual activity and valvular heart disease, they recommended that sexual activity is reasonable for the patient with mild to moderate valvular heart disease and no to mild symptoms. Sexual activity is reasonable for the patient with normally functioning prosthetic valve, successfully repaired valve, and successfully transcatheter valve intervention. And sexual activity is not advised for the patients with severe or significantly symptomatic valvular disease until their condition is stabilized and optimally managed. And some recommendation for the sexual activity and congenital heart disease. So sexual activity is reasonable for most congenital heart disease patients who don't have decompensated or advanced heart failure, severe and significant symptomatic valve disease, or uncontrolled arrhythmia. Now, what's the recommendation about arrhythmias, pacemaker, and ICD for the sexual activity? They said that sexual activity is reasonable for the patient with atrial fibrillation and atrial flutter and when controlled ventricular rates. Sexual activity is reasonable for the patient with history of atrioventricular nodal reentrant tachycardia, AVRT, and atrial tachycardia, and also the controlled arrhythmia. Sexual activity is reasonable for the patients with pacemaker or ICD implant for the primary prevention. Sexual activity is reasonable for the same thing, ICD for the also for the secondary prevention. In whom moderate physical activity does not precipitate ventricular tachycardia or fibrillation, and who don't receive frequent multiple appropriate shocks. This is more important for the patients with ICD or AICD. Sexual activity should be deferred for the patient with AF and poorly controlled ventricular rate, uncontrolled and symptomatic supraventricular tachycardia, and spontaneous exercise-induced ventricular tachycardia until the condition is optimally managed. And sexual activity should be deferred in the patient with IACD who have received multiple shocks until the positive arrhythmia is stabilized and optimally controlled. Sexual activity and HOCM, though it is reasonably good for the most patients of the HOCM, but sexual activity should be deferred for the patients with SCM who is severely symptomatic until their condition is stabilized, and SCM with severe outflow obstruction. Cardiovascular drugs and sexually functions. So cardiovascular death can. This is a very good recommendation that we all should keep in the mind, that cardiovascular drug that can improve symptoms and survival should not be withheld because of the concern about potent impact on the sexual function. And what about the topical and local estrogen therapy? So they said that non-systemic estrogen use for the treatment of dyspareunia in women with CVD is reasonably good. Herbal medicine, they said that it may be reasonable to caution patient with CVD regarding the potential for the adverse effect of the use of the herbal medicine with unknown ingredient that are taken the treatment for the sexual dysfunction. And they always emphasis on the patient and partner counseling both. That patient and spouse counseling by the healthcare provider is useful to assist in resolution of sexual activity after an acute cardiac event, new cardiovascular diagnosis, and ICD implantation. Usually, I counsel both the partner post CABG and post any cardiac procedure after 2 weeks in each and every couple. And I insist the patients to come with the spouse for that matter. Sexual activity and PD5 inhibitors, we all know that it should not be combined with the nitrates, and they said that PD5 inhibitors should not be used the patient receiving nitrates, and nitrates should not be administered to the patient within 24 hours of the sildenafil administration or the within 48 hours of the tadalafil administration. But they said that you can give sildenafil or tadalafil for the treatment of erectile dysfunction in patients with a stable CVD. So, the counseling of the patient with the cardiac disease regarding the sexual activity advice must be individualized. In a general, if patients are stabilized, they may resume normal sexual activity within 2 to 6 weeks. A graded ETT exercise treadmill test may be the value in the higher risk patients. The clinician must be alert to potential medication effect that may be a contributing factor to the sexual dysfunction. Patients should be warned of symptoms with sexual activity that should generate evolution. For example, palpitation, shortness of breath, angina, fatigue, etc. And alert their physician should this occur. And finally, the physician should be proactive in assessing and counseling patients regarding sexual functioning. And in general, if the patient can achieve 5 minutes on exercise treadmill test without demonstrable ischemia or significant arrhythmia or any symptoms, they are generally not at high risk to resume normal sexual activity. Similarly, if echocardiography does not yield evidence of more than moderate LV dysfunction, resumption of sexual activity is probably safe. Herewith, I would like to invite all of you for the upcoming 11th National Annual Conference of the Indian Association of Clinical Cardiologists IACC 2022 at Vadodara, Gujarat. खुद दिन तो गुजारो गुजरात में. Thank you very much. If any question, I would like to